My name is Dr. Lloyd Hiebert. I'm a physician anesthesiologist, and I am thrilled to be part of this veterinary webinar. For the past 25 years, I've developed patient positioning and warming systems for both the medical and the veterinary OR. I especially enjoy working with veterinarians because they are passionate about excellence in patient care and because they're open to new and innovative ideas to improve that care. We can all learn from each other, and I hope that what I have to share today will be a benefit to patient care in your practice. With that, let's jump right into a topic that I'm passionate about: hypothermia, pathophysiology, and prevention. In this webinar, we will define hypothermia. We'll talk about the 4 mechanisms of heat loss, the importance of the core and peripheral compartments of the body in hypothermia, the 3 phases of hypothermia during anesthesia, the complications of hypothermia, and prevention of hypothermia preoperatively, intraoperatively, and postoperatively. Well, what is hypothermia? I'm certain I don't need to school any of you in telling you what the normal temperature of a dog and cat might be. The progression of hypothermia, however, is a very slippery slope, and intervention needs to occur early. Mild hypothermia is 98 to 99.9 degrees Fahrenheit. Moderate, 96 to 98. Severe hypothermia, 92 to 96 degrees Fahrenheit. And critical hypothermia is 92 degrees Fahrenheit or less. To understand how hypothermia occurs, understanding the mechanisms of heat loss is very important. The number 1 cause of heat loss is radiation, which is the transfer of body heat in the form of infrared radiant energy to cold objects not in contact with the body. For example, heat loss to the walls of a cold OR. If you look at that, the picture of an OR down below, you can just imagine they've got cold air-conditioned air, there's cold walls, there's cold floors, there's also cold OR tables. Convection, the loss of body heat by the physical movement of ambient air. For an example, this is heat loss to the cold circulating OR air. So 90% of heat loss in surgery is by radiation and convection. Conduction, this is the direct flow of body heat to surrounding surfaces. An example here is heat loss to a cold OR table. If you look at these beautiful stainless steel OR tables that are manufactured by these wonderful fabricators in the Midwest, they're beautiful, but they are an absolute heat sink unless there is an adequate insulation between the patient's body and the cold OR table. There's going to be a direct transfer of heat from the patient's body to the cold OR table. Evaporation. This is the loss of body heat by evaporation of warmed moisture. And an example here is when you're prepping an abdomen with alcohol or betadine, and as that alcohol and betadine dries and evaporates, it takes with it body temperature as well. To understand the patient heat loss during anesthesia, it's instructive to divide the body into the core compartment and the peripheral compartment. The core compartment is the head and thorax, and this comprises 50 to 60% of body mass. And here the temperature remains relatively stable. The peripheral compartment, of course, is the legs, and the temperature is 3.6 degrees Fahrenheit to 7.2 degrees Fahrenheit cooler than the core temperature. So there's a temperature gradient between the core and the peripheral compartments, which is normal. So the temperature of the peripheral compartment can fluctuate dependent upon the ambient temperature. So this cartoon below here is pathophysiologically prophetic. The big guy here is saying, my paws are freezing. What he's saying pathophysiologically is this: my peripheral compartment is getting very cold. In fact, it's getting so cold that I'm having compensatory peripheral vasoconstriction. And this is redirecting blood flow to my core compartment so that my core compartment can remain stable. That's a mouthful, but that's what he's saying. The little guy is saying, buddy, you think you've got problems. Well, this little guy indeed does have problems because he's having cooling of both his peripheral and his core compartment, giving him significant difficulty with regard to maintaining his body temperature. As we mentioned, the core peripheral temperature gradient is normal. And this gradient is controlled by the hypothalamus to mitigate heat loss to the environment by peripheral vasoconstriction, which redirects blood flow from the peripheral to the core compartment. If you look back at the cartoon, because the patient has cold legs, the blood is being redirected to the core compartment. There's also increasing metabolic heat production, and this is to maintain stable core compartment temperature. So the peripheral vasoconstriction and metabolic heat production is a consequence of neurogenic thermoregulation. So the hypothalamus in this instance exists to maintain stable core compartment temperature. So with general anesthesia, we have a loss of thermoregulation by the hypothalamus, and this causes vasodilation because virtually all anesthetic drugs are vasodilators, except maybe ketamine. So there's a loss of compensatory peripheral vasoconstriction. There's a flow of warm core blood to the periphery where it is cooled by the four mechanisms of heat loss that we talked about. So the patient essentially becomes a heat radiator. And the loss of thermoregulation also decreases metabolic heat production because there's a decrease in metabolic rate by 20 to 40%, and consequently a drastic drop in heat production. So when we're considering hypothermia during the course of anesthesia, it's instructive to look at hypothermia in three phases: phase 1, phase 2, and phase 3. In phase 1, we have a very rapid decrease in body temperature. And this occurs in the first hour of anesthesia. And this is caused by redistribution of blood flow from the core to the peripheral compartment due to peripheral vasodilation by anesthetic drugs. Body heat is then lost through the skin by the four mechanisms of heat loss that we talked about. The redistribution of blood flow depends on the core to peripheral temperature gradient that we also talked about. If there's a large gradient, there's a greater warm core blood flow to the periphery. There's no compensatory peripheral vasoconstriction. There's a loss of thermoregulation. Remember, this is a number to remember. In phase 1, accounts for 81% of temperature decrease during the course of anesthesia. Remember this number, 81%. So phase 1 is the time when interventions are the most effective. I understand that your veterinarian patients are not particularly cooperative prior to anesthetic induction. So active warming must start immediately upon anesthetic induction. In phase 2, we have a slow linear decline in body temperature, and this can last for 2 to 4 hours. And this is where heat loss exceeds metabolic heat production, and that is because the hypothalamus is being rendered inactive by the general anesthetic. The rate of temperature fall depends on, firstly, the difference between heat lost and heat produced, and number 2, the mass of the patient. As you know, animals have a large surface area to mass ratio, and this is why a Chihuahua loses body heat much more rapidly than a Saint Bernard. So in phase 2, there's also a decreased metabolic rate, and consequent heat production is reduced by 20 to 40%. In phase 3, we have a virtual temperature plateau. We have core temperature stability, and this occurs after 3 to 4 hours of anesthesia. And this is where metabolic heat production equals heat loss. If you look at this poor sheep, which is embedded in a snowbank, this sheep has core temperature stability. Its metabolic heat production equals its heat loss. So what are some of the deleterious effects of hypothermia? I suspect that if our patients knew what happened under general anesthesia with hypothermia, they might think twice. But let's just go through them. It can range anywhere from cardiac arrhythmias to decreased platelet aggregation, impaired kidney function, impaired liver function, surgical site infections, poor wound healing, increased recovery time, and death. So how do you monitor a patient intraoperatively in the most accurate fashion possible? Well, the esophageal temperature most closely represents core body temperature. And if you look at this anatomical drawing, the esophagus, as you can see, is in direct contact with the posterior wall of the left atrium and very near the pulmonary vessels. So there's probably not a warmer area in the body than right here. So that's the optimal site of temperature monitoring. If you can't do that, rectal is possibly second best, although it does not represent core or your peripheral temperature. So how do we prevent hypothermia? Well, as you know, there are a myriad of patient warming devices out there, and this webinar has not been created to endorse any particular warming device or system. There are passive warming devices like thermal retention blankets, active warming devices such as forced air warming, electrical warming, circulating water warming. Okay, preoperative warming. If you look back to your veterinary education, and you remember some of your lectures, like some of the lecturers probably said, if you don't remember anything about this lecture, remember this slide. Okay, this is that slide. Preoperative warming. With general anesthesia, the flow of heat from the core to the periphery is massive. That's because of the vasodilation. And you have 81% of temperature decline during phase 1. So you want to warm the core and peripheral compartments as much as possible preoperatively to increase the temperature of the peripheral compartment, because this will decrease that temperature gradient. This prevents redistribution hypothermia because there's equalization of the core peripheral temperature gradient, because now you don't have any warm core blood being cooled in the periphery. So you want to use active warming during pre-op prep as much as is practically possible. I certainly understand that, as I mentioned before, your veterinary patients may not be very cooperative prior to that. So you want to start active warming immediately upon induction of anesthesia. So numerous studies have shown that for pre-op warming to be effective, it needs to be done for at least 30 minutes. And this can be done while you're prepping. This prevents the very rapid phase 1 decline in body temperature. It's also important to remember that the heat that is stored in the peripheral compartment preoperatively is transient. So you want to minimize the delay between preoperative and intraoperative warming. So if you've done a great job of preoperative warming in your pre-op room and you're moving that patient to your operatory, as soon as physically possible, continue your active warming. And what you may also need to do to prevent radiant and convective heat loss, you may also need to use some type of a passive warming device. Because for every minute of delay between pre-op and intra-op warming, the likelihood of a drop in core temperature is increased by almost 5%. So remember, 81% of temperature decline occurs in phase 1. Effective pre-op warming with minimal delay to intra-op warming are the two most important steps you can take in maintaining normal thermia. Intraoperative warming. Again, minimize the delay between pre-op and intra-op warming. The heat stored in the peripheral compartment is transient, so don't delay. You want to expose as much of the patient's body area, the patient's body surface area to your warming device as you possibly can. And obviously, when you're doing over body warming, you do that in non-sterile areas. However, there is very frequently inadequate area of coverage. If you look at the slide down below, you see the lower part of the chest exposed as well as the entire abdomen. So there's not a lot of over body surface area left to provide active warming. When you're doing underbody warming, use appropriate warming devices. You want to use warmed IV fluids. When you're doing an abdominal procedure, you want to irrigate with warm surgical irrigation, and irrigate with warm irrigation at least 3 times so that you have transfer of heat to the mesenteric and the intra-abdominal blood vessels. So we also want to decrease convective heat loss, and this is best done by maintaining an appropriate room temperature. And the appropriate room temperature appears to be about 73 to 78 degrees Fahrenheit if, and I say if, the surgeons can tolerate, because I've done surgical procedures as well, and at 78 degrees Fahrenheit, it's not very comfortable for the surgeon. Postoperative warming. So you want to maintain active warming until the patient emerges from anesthesia. Postoperative return to normal thermia occurs when brain or hypothalamic anesthetic concentrations decreases sufficiently to again trigger normal thermoregulatory defenses. And this is compensatory peripheral vasoconstriction and metabolic heat production. So why is normal thermia important? Well, it's important, as you know, physiologically as well as economically. As you've seen, the hypothermia that we talked about certainly affects an animal's physiology. And normal thermia prevents the deleterious effects of hypothermia. When you're normothermic, when you have a patient that's normothermic, The hepatic enzymes and renal excretion will be more effective in metabolizing the anesthetic medications, and you're going to have a very rapid emergence from anesthesia. Well, normothermia is also important economically. When you have excellent patient care and you have a normothermic patient intraoperatively, you're going to have decreased recovery time and you're going to have increased clinical efficiency. Numerous studies have been done regarding the economics of effects of hypothermia on the medical side, and they've been able to show that a decrease of 2.5 degrees Fahrenheit below normal thermia intraoperatively will create a patient bill upon their discharge, which is $2,500 to $7,000 more than had they been normal thermic intraoperatively. And this is because of increased recovery time and increased postoperative complications. I've also spoken to some very financially astute veterinary clinic managers, and they've indicated to me that their recovery time costs are from $100 to $125 per hour. So can you imagine if you maintained normal thermia intraoperatively and you were able to decrease your recovery time by half, how that would affect your clinic revenue? So increased clinical efficiency equals increase in clinic revenue. So normothermia, as we've been able to see, so normothermia is important physiologically as well as economically. So in summary, we've defined hypothermia. We've talked about the 4 mechanisms of heat loss. We've talked about the core to periphery redistribution with anesthetic induction and the gradient that occurs. We've talked about the 3 phases of hypothermia during anesthesia, the deleterious complications of hypothermia. We've talked about prevention of hypothermia preoperatively, the vital importance of pre-op warming and minimizing the delay to intra-op warming, and that this is when intervention is most effective. And to remember that 81% of temperature decline occurs in phase 1. We also talked about the prevention of hypothermia intraoperatively and postoperatively. Well, I've been honored to have participated in this veterinary webinar. I hope that what I have shared will be of benefit to your practice. If you have any questions or you have any comments from which I can learn, you certainly are welcome to email me at vetwarmingsolutions@gmail.com. Thank you very much.